Today, I'm going to present about tracheal stenosis. First, I'm going to talk about the causes and prevalences of tracheal stenosis. There are many causes of tracheal stenosis. Basically, anything that can cause ischemic injury and necrosis could potentially lead to tracheal stenosis, such as injury from prior tracheostomy or prolonged intubation, infection, tracheitis, radiation injury, and inflammatory disease involving the trachea could also cause tracheal stenosis. When there is no identifiable cause, then this is idiopathic tracheal stenosis. Post-tracheostomy or intubation tracheal stenosis is very common. In fact, it is one of the most common complications of tracheostomy. It happens in about 28% of all the complications related to long-term tracheostomy. And in patients who were intubated more than 14 days, prolonged intubation, then there is a risk of tracheal stenosis as well in about 10 to 20% of these patients, especially in patient who is of a smaller size, patient who are obese and has a bigger endotracheal tube placement can also develop tracheal stenosis when they're intubated for a long time. Regarding the post-tracheostomy or intubation-related tracheal stenosis, there have been studies about the characteristic of this stenosis. So for example, this study retrospectively reviewed 115 cases of post-intubation or post-tracheostomy tracheal stenosis, and apparently from this study, a lot of these patients has complex stenosis, complex meaning more than 1 centimeter in length, and involve multiple level of trachea. So 66% of these patients has complex stenosis, especially in patients who had longer intubation and patients who previously had tracheostomy. The most common location of this segment of stenosis was in the upper third of the trachea, technically where the cuff of the tracheostomy tube or endotracheal tube was. Moving on to idiopathic tracheal stenosis. So whenever there is no identifiable cause of tracheal stenosis, then it's considered idiopathic. It is considered a very rare condition. It affects only 1 in 400,000 population. Although this is rare, but this disease is very, very challenging to diagnose and treat because it is commonly misdiagnosed as asthma or COPD for like wheezing and shortness of breath with no parenchymal lung disease. And it frequently recurs even when it is appropriately treated. And idiopathic tracheal stenosis could be from mild to severe. In severe cases, it can lead to life-threatening dyspnea and difficult intubation. How to classify tracheal stenosis? So the most common way is to classify it as either simple or complex. So simple tracheal stenosis involves only less than 1 centimeter in length of the stenotic segment, and there's no loss of cartilaginous support, and there's no tracheomalacia. For complex tracheal stenosis, it involves more than 1 centimeter or multi-level tracheal rings closer to the vocal cord, and it can also accompany with tracheomalacia, and there's loss of cartilaginous support. For complex tracheal stenosis, then the treatment is usually very difficult. There are other classification such as Kaplan-Meier's. So Kaplan-Meier's classification involve just the obstruction level. It has 4 grades. Grade 3 and 4 are the more severe grades. Grade 3 involve any stenosis from 70% to almost 95% of the lumen, and grade 4 is when there is no detectable lumen. Freytag classification has more details in it. It involves the types, locations, and degree of stenosis for the classification. For tracheal stenosis, it is very important to make sure that there's no other segment of the airways involved before you call it just tracheal stenosis. For example, this patient has tracheal stenosis for a long time, but in fact, he also had supraglottic and glottic stenosis. In addition to the tracheal stenosis, especially in this patient who had prior thyroid surgery or any risk factor for recurrent laryngeal nerve damage, we have to be careful about multi-level obstruction. This patient had the supraglottic obstruction as well from the, let me show this again, from the left vocal cord paralysis and subluxation of the left uh, arytenoid cartilage. And so even when you treat the tracheal stenosis, he will still have difficulty breathing. So in this kind of patient, you have to also involve ENT in the treatment. Next, I'm going to discuss about the mechanism of tracheal stenosis. So, stenosis actually is a very interesting disease. It is sometimes compared to the condition that can cause keloid on our skin. So, first of all, we need to talk about wound healing. So, there are four phases of wound healing. First is hemostasis. Second is inflammation. Third is proliferation, and fourth is remodeling. So the phases that involve tracheal stenosis is mostly the inflammation phase, proliferation phase, and remodeling phase. So after there is damage onto the mucosa, after hemostasis and inflammation, then there is this proliferative phase where monocytes differentiate into activated macrophages, and these macrophages then secretes other cytokines as well, especially tumor growth factor beta, which stimulates fibroblast and epithelial and endothelial cell growth and proliferation at the injured site. And these fibroblast proliferation can lead to excessive scarring. So in studies where they analyzed the models of dermal injury, they found that the scars usually are linked to the special fibroblast cell lineage, especially in patients who had laryngeal tracheal stenosis. These fibroblasts around the site of the stenosis exhibit higher rates of migration. It migrates faster. It also proliferates faster than other part of the normal airway, and it also has higher contractility from other part of the normal airway. And one thing that's interesting is that there is something called the Warburg effect in cancer cell, right? The laryngeal stenosis cells also had kind of a similar activity where fermented glycolysis under aerobic conditions in the stenotic area. So in patients who had type 2 diabetes, these patients are higher risk to develop idiopathic laryngeal stenosis, and this risk is almost 8 times higher than people who don't have diabetes. In this particular patients with diabetes, the fibroblast it exhibits myofibroblast with higher contractility, increased collagen phosphorylation compared to other normal fibroblasts. In some studies, they propose a medication to potentially have a role in treatment of idiopathic laryngeal stenosis, such as amylbarbital, because amylbarbital could potentially reduce cellular conductivity and collagen production by decreased expression of COL1 protein. And so further study is needed to learn about this potential role of amylbarbital. Almost 95 or more percent of the patients are female, and so there have been a lot of questions regarding this. There is no convincing evidence about why this phenomenon happens, but in a retrospective analysis of 42 surgical specimens from idiopathic stenosis female patients, they compare the uh, these patients with the patients don't have the tracheal stenosis, and they found that the expression of estrogen estrogen receptor alpha was higher in postmenopausal stenotic patients, and this expression of the estrogen receptor alpha also significantly higher compared to the control patients. Next, I'm going to talk about the clinical presentation of tracheal stenosis. So most common presentation is dyspnea at rest or on exertion, depending on the diameter of the stenotic segment. So whenever the diameter is less than 5 millimeter, then the dyspnea is usually at rest. And when the diameter is less than 8 millimeter, then the dyspnea is on exertion. But this is all relative. It also depends on the patient's original tracheal size as well, and also depends on the acuity of the stenosis. There have been patients who had this condition for many years, and although they have a very severe obstruction, they basically compensate to it. So they may not complain a lot. When the stenosis is severe enough, it will show fixed airway obstruction, um, similar to this picture. So flattening of the expiration and inspiration curve can be observed in patients who already have at least moderate to severe stenosis. When the obstruction is not as significant, you may or may not see this manifestation on the PFD. Imaging study. So be careful about imaging study, because CT scan a lot of time can underestimate the obstruction. It's mainly because the obstruction usually on a multi-level, instead of just a 2D view on the CT scan. So for example, this patient on the left hand side CT scan, you don't see as much as a severe obstruction. um, Here you can see this area. Here's the obstruction. It's measured about about 8 or something, 7 or 8. But in fact, during endoscopy, it looks a lot worse. This area is only about 4 millimeter. I could not even pass the P190 scope through this. So obviously, CT can underestimate the obstruction. And one thing that I have to also mention is that a lot of time radiologists usually they can miss the stenosis as well, because like I said, it's not a very common entity. So and it's so don't just trust your CT scan. If you have any medical suspicious or for tracheal stenosis, you should trunk the patient. Okay, so next we're going to talk about the treatment of tracheal stenosis. So after you diagnose a patient with tracheal stenosis, what is the treatment? So there are two main treatment of choice. One is cryotracheal resection, and the other one is endoscopy measures. So cryotracheal resection, basically removing the area of obstruction by surgery. So first of all, let's review the anatomy of the larynx and the subglottic and tracheal space. So the larynx is comprised of the thyroid cartilage, and then the cricoid cartilage, and then the recurrent laryngeal nerve that runs posteriorly between the trachea and the esophagus, and it innervates the intrinsic muscle of the larynx. Whenever there's damage of this recurrent laryngeal nerve, then there will be like incomplete vocal cord paralysis, abductor and adductor paralysis. I'm not gonna focus too much about this, but the whenever there's a resection of the area of obstruction, one have to be very careful about damaging the recurrent laryngeal nerve. Whenever that happens, it can lead to vocal cord paralysis, and so even when the tracheal stenosis is already resected, the patient's still gonna have problem with breathing. So that can be a very bad complication when that happens. This is the diaphragm of how they can remove the stenotic segment. Though basically they remove the anterior part of the cricoid, and then the affected trachea, and then they do the anastomosis like this. There's a lot of limitation before the patient can get to surgery, because this is obviously um, a very extensive procedure, a very long, extensive procedure with high complication rates, and so it's mostly performed in tertiary care centers in experienced hand, and even so, there's a limit of less than 4 centimeter in tracheal stenosis length before the surgeon can remove this, because if you remove too much of a trachea, then the patient won't be able to extend the neck. So the stenotic have to be short enough, and then there should be no prior neck radiation and no prior tracheal surgery. Diabetes have to be very well controlled. Patient should not be on any steroid therapy. Patient should not have any severe medical comorbidities. Patient should have perfect lung function. Patient should not have any extensive cancer in the trachea. And so uh, the um, the selection criteria for this resection is quite extensive. But the good thing about this resection is that whenever the patient already have the segments removed, then the recurrence rate of the tracheal stenosis is very low, about less than 10% of the time, compared to 40% to 50% of the time with conservative management. Next, I'm going to discuss about the comparison of the treatment modalities. So, like I said, there are two main type of treatment: surgical removal, cryotracheal resection. Second is endoscopic resection or dilatation. Okay, so this is a very good study published in 2020. They did a retrospective analysis of 810 patients with idiopathic subglottic stenosis who underwent one or three of the most common surgical treatments. The recurrence rate of these three interventions are strikingly different. As you can see on the right picture here, the probability of avoiding disease recurrent percentage in cryotracheal resection is extremely high. The next is the endoscopic resection with adjuvant medical therapy is the second, and then the last is endoscopic dilatation. So the recurrence within 3 years for cryotracheal resection is only 1%, versus 12% in the endoscopic resection with adjuvant medical therapy, versus endoscopic dilatation with recurrent rates of 28%. So we know that cricottracheal resection has the highest rate of achieving no recurrence in 3 years. Um, what about the voice? Interestingly, the voice handicap index for patients who underwent surgery actually worse compared to the patients who underwent endoscopic resection of the stenosis and medical therapy. This surgical treatment was not different compared to endoscopic dilatation. In regard to the complications of the three different modalities, the cricothyroid resection has the highest complications. 9% of the patients require temporary tracheostomy or T-tube. 9% of the patients had to come back to the operation room, and 8% of the patients developed permanent unilateral vocal cord paralysis, and 3% of patients had anastomotic leak. And for the group of endoscopic resection with adjuvant medical therapy, there are mostly just temporary complications such as tongue paresthesia or dental injury. Um, the surgical group certainly has more complications, um, but it seems to be that those complications are potentially treatable as well and not permanent. Um, for the endpoint of breathing, the treatment with cricottracheal resection, although it's accompanied by a higher rate of complications, but it does achieve better breathing score at in 1 year compared to two other treatments. And interestingly, the treatments with endotracheal resection and medical therapy show better breathing outcome compared to treatment using just dilatation. So, in summary, this is a pretty pretty good study, although it's retrospective, but they involve a lot of patients and they follow these patients up in 3 years. So, fairly good study. Um, as you can see, trichotracheal resection is accompanied with the highest complication rate and with multiple procedures, essentially. However, it does achieve very remission, avoiding the disease recurrence of only 1% of recurrence rate in 3 years. And then the patient breathed a lot better in 1 year compared to the two other mobilities, although it has lower voice handicap index compared to the two other treatment mobility. In patients who are not a surgical candidate, endoscopic resection with adjuvant medical therapy achieve a higher, actually a lower recurrence rate, and then a better breathing outcome compared to just endoscopic dilatation. So let's talk more about wedge resection and triple therapy. Um, there are only this is the treatments specifically done by the ENT college. This is a study which retrospectively reviewed 183 patients with idiopathic subglottic stenosis. All these patients underwent primary or secondary laser wedge resection in combination of triple medical therapy, fluticasone, Bactrim, and omeprazole. The rationale about the triple medical therapy is not mentioned in this presentation, but there are a lot of data. There are some data about this. Anyway, in this study, they proved that the median time to recurrence of another procedure for primary and secondary laser wedge resection is 4.1 and 2.9 respectively. Patients who underwent primary laser wedge resection had a median time to recurrence of 4.1 year, and 4.1 years before they can get another procedure. This is strikingly good. Laryngeal idiopathic tracheal stenosis is known to be recurring very frequently, at least every 4 to 6 months, based on other studies. You can see that the patients who compliant to the triple therapy with a lowest chance of recurrence, no number of recurrence compared to the other two groups who were not compliant to medical therapy. So triple therapy compliance may play some role in this treatment of tracheal stenosis. One more thing that I have to talk about is A-frame stenosis. So A-frame stenosis is when there was a fracture of the cartilage ring, and so the anterior tracheal ring were fractured, and so there's no support of the anterior wall of the trachea. So the other two lateral side of the tracheal ring come together and create this A-frame stenosis. And this kind of stenosis is very difficult to treat because it does not respond to bronchial balloon it does not respond to tracheal balloon dilation, and there's not a lot of scar tissue to ablate with the laser. This is an example of how they use the laser to remove some of the cartilage structure, but you have to be very careful not cut the area close to the posterior wall and then the anterior wall, and there's also a risk of air leak as well if you some perforation with the wet resection. But the stent is also very difficult to stay well through this area. The treatment of choice actually resection if the patient is a surgical candidate. So what about stents? Stents certainly have some role in tracheal stenosis treatment. The benefit of stents are especially stressed in complex stenosis when the patient is not a surgical candidate. And it may be a bridge to surgery when the patients have to wait for surgery with a lot of symptoms. This is just anecdotal advice, but there's no data for this yet. Multiple other reasons for dyspnea, including tracheal stenosis, morbid obesity, etc. A stent trial in this patient can help us to find out which is the main reason for the patient to have dyspnea, an acute tracheal ring rupture, which kind of act as like a splint to prevent this A-frame stenosis like I showed you earlier. However, not very good data for this yet. We have to be very careful about stents because it risk of extending the stenosis segment whenever the patient is a surgical candidate, and if the stenosis segment increases in length, the patient might not be a candidate for surgery anymore. For example, if the stenotic area move closer to the vocal cord, or involving the posterior segment of the cricoid, then the patient is no longer a surgical candidate. So we have to be very careful about placing stent for this patient, unless you're very, very sure that she or he is not a surgical candidate. There is also a lot of risk for migration and respiratory failure. 60% of this risk, because the trachea, especially the upper trachea, is a very mobile structure and it can extend and flex. And so the angle of this trachea in the upper part is also not straight. In fact, it's flexed anteriorly and the stent is very straight. So there is a significant risk of migration with stent being placed. So we have to be careful about that. Um, this is a case example of what I just talked about. So this is the patient who had tracheal stenosis, idiopathic tracheal stenosis, which is about 2.5 centimeter below the vocal cord, as you can see here. Um, this patient underwent multiple endoscopic treatments with recurrence every 3 or 4 months. Um, the patient um, decided to the patient decided that she wanted to have a stent trial So a stent was placed for this patient through the stenotic area. And as you can see here, this is after the stent was placed. This is the proximal end of the stent. This is the distal end of the stent. And after 3 months, the patient presented with worsening shortness of breath, and she could not even walk, despite that the stent on the CT scan was reported as patent on the left hand side here. But actually, if you look at this picture more carefully, you can see that in front of the stent, right above the stent, there is a significant stenosis right above the stent. There is a significant narrowing right above the stent. The stent is no longer visible. This narrowing is only 3 to 4 millimeter at most, and it's significantly narrow. It's even narrower than before the stent was placed. After that, the patient end up having two stenotic area instead of one. So the stenosis area actually has been extended beyond the original obstruction, and she potentially not going to be a surgical candidate anymore. So this is the example of how stents can be problematic for patients who had tracheal stenosis. So be very careful with stents. Some very minor evidence of mitomycin application and steroid injection as well. I'm not gonna focus too much about this. There are many type of stents that can be placed for this patient who has tracheal stenosis. Um, so in patient who is not a surgical candidate, and I'm stressing not a surgical candidate, Montgomery T tube, which can also be placed for patient who already has a tracheostomy tract. In summary, tracheal stenosis is a difficult to treat condition. It requires multidisciplinary approach, including interventional pulmonology, ENT, and thoracic surgery to determine the treatment options. Um, the treatments have to gear toward the patient's symptoms and careful evaluation of the supraglottic, glottic, and tracheal segments, voice function, aspiration. Um, Treatment of choice is cryotracheal resection. In patients who meet the selection criteria, it's maybe worthwhile to ask for a second opinion from surgical college before you consider that this patient is certainly not a surgical candidate. When the patient is definitely not a surgical candidate, the treatment of choice is endobronchial resection, endobronchial dilation. Endobronchial resection of the scar tissues is possible by laser or electrocautery, and it has the lower recurrent rates compared to just dilation. And treatment is have to be very careful before you consider that. Tracheostomy tube and Montgomery T tubes are also treatments consideration. Thank you for your attention.